everybody, and happy Friday. Thank you so much for being here for our Best Cares presentation. We are so fortunate to have Dr. Ari here to talk to us about cholesterol. We have not had uh, a presentation on cholesterol, I don't think ever in Best Health's uh, last 8 years. So we're super excited. Dr. Ari is the medical director of the Baptist Stern joint venture, and he oversees the cardiovascular services for the Metro Baptist Hospital System. Also, medical director of the Heart and Vascular Institute, co-director of System Cardiovascular Service Line, and director of Cardiovascular Services and Echo Lab at Baptist DeSoto. So also the director of quality for Stern Foundation. And that is a lot. We are very lucky to have you today. And thank you everybody for being here. If you'd like to put your questions as we go in the chat, we will be getting to those at the very end of the presentation. And without further ado, I am going to share the slide deck. And thank you, Dr. Ari.
Hey, thank you. Thanks for having me here. I'm sorry that my camera's not working, so I can't put my face on here, but it's a pleasure to be able to speak with you about cholesterol. What I'm hoping is that after this educational session, some of you who will have all of you will have a better understanding of why cholesterol is an important risk factor to know and to control, and how it can impact you and some of the options that you have. So let's move on to the next slide. All right, so there's many different types of cholesterol. Cholesterol is one of the components of what creates the plaque in your arteries, otherwise known as hardening of the arteries or atherosclerosis. Peripheral arterial disease is when that hardening takes place in the arteries in your legs or in your neck. Coronary artery disease is when it takes place in your heart arteries. It could be in any part of the body where blood is supplied to provide important oxygen, nutrition, energy to the organs. Plaque can build up in those arteries and prevent the blood flow from getting to those organs, and in turn can damage those organs. And cholesterol is a major component of that plaque buildup. There's different types. There's that we'll talk about in just a moment. Next slide. So on the left here, you see what it looks like when plaque develops in an artery and how it builds over time. Sometimes plaque gradually builds in an artery and closes the artery over a period of time. And when that happens, individuals, depending on which artery is getting closed down, individuals might feel symptoms from that gradual closing. For instance, if you happen to have an artery in your heart that's gradually closing, the symptoms that you might experience are symptoms with exertion. So if you're somebody that walks regularly, you may notice one day that it's getting a little bit harder to walk, but you're not quite sure if that's really a problem. But over time, it's pretty clear that when you walk, you're limited by a discomfort in your chest, maybe shortness of breath, maybe you get very fatigued, but something is clearly evolving. That is a stable presentation. The plaque made up of cholesterol has grown gradually over time. The other way that people may notice things is when plaque ruptures and an artery clots suddenly. That happens in the setting of a heart attack. You may be at home, you may be at work, you may be out traveling somewhere, and suddenly out of the blue, something hits you in your chest. You feel a sudden discomfort in your chest. It could be a squeezing, a pressure, a tightness, maybe radiation down both arms, maybe into your neck. You might be nauseous. You may feel like you want to vomit. but something is clearly happening and it's not going away. And under those circumstances, 911 is the right number to call and to get to the emergency room right away. And those are the two ways that arteries that get clogged up tend to present themselves. And you can see on the picture on the right, your arteries supply blood to all the organs. You know, the brain, the eyes, the heart, the kidneys, the organs in your stomach, your legs, your arms, everywhere. And any of those arterial beds can get clogged up uh, if your cholesterol is abnormal. And let's go to the next slide. So what are the components of cholesterol that you need to know? You know, generally around the age of 40, unless there is a strong family history of cholesterol problems, genetic problems. Usually at age 40 is when we first start to have our cholesterols checked on a routine basis. You go to your doctor, and they break down the cholesterol into different components. Low density lipoprotein, that's the cholesterol that binds to the arteries. That's the most damaging component of cholesterol. Then you have the high density lipoprotein component of cholesterol. That's the protective component. The more the HDL you have, the better protected you are. In general, it's ideal to have no more than 2 LDLs for every 1 HDL. That's an important number to remember when you talk to your doctor. Non-HDL is another atherogenic particle, meaning creates atherosclerosis and hardening of the arteries. That is another target for you and for your physician to try to lower. There's triglycerides. They also play a role, not as important as the first three I mentioned. Um, Typically, when these are very high, the more pressing concern is that it can cause something called pancreatitis. Triglycerides are the component of your cholesterol that are most closely tied to the way you eat. And when we have very high levels of triglycerides, you may see that in thyroid disease, you might see that in diabetes, and especially poorly controlled diabetes, and you may see that in individuals who have poor diets. But sometimes that can be a genetic problem as well. And then there is a genetically predisposed particle called lipoprotein little a, and individuals who have high levels of lipoprotein little a, they have a propensity to develop cardiac or vascular events earlier in life, such as strokes or heart attacks. Um, and you could see on the in the picture there the optimal healthy cholesterol range, and that's in the green. And usually it's in milligrams per deciliter that we get the results. Um, this is for individuals who have no risk factors at all. So if you're 40 years old and you don't have high blood pressure, you don't smoke, you don't have diabetes, you don't have an early family history of heart disease, um, your ideal total cholesterol is less than 200. Your ideal LDL is less than 130. Your ideal HDL is greater than 60, triglycerides less than 150, non-HDL less than 130, and a triglyceride to HDL ratio less than 3, and an LDL HDL ratio less than 2. But remember, these are for people who have no risk factors at all, and that is not a common thing in life. Many of us are carrying around some sort of risk, and for that reason, your doctor may talk to you about ways to lower your cholesterol. Next slide. So how do you know if you need therapy? So typically you may go to the doctor once a year for a general checkup. You may go twice a year. A lot of it depends on your age. A lot of it depends on whether or not you have any major issues that need to be followed closely. But your doctor should assess your risk. That's one of the first thing your doctor needs to do. What is the risk of you having a cardiovascular event and is your doctor focusing on primary prevention or secondary prevention? Primary prevention is what do we do about managing cholesterol in individuals who have no evidence of vascular disease? Secondary prevention, the rules are a little bit different. What do you do for somebody who has evidence of vascular disease? And then once you've determined those two issues, what kind of person are you? Are you somebody who has disease or doesn't have disease? Are you then a low risk person? Do you have intermediate risk or are you a high risk person? One of the ways that you can quantify your risk is through a scoring tool. There are several different kinds of scoring tools. One is called the MESA risk score. The MESA risk score includes things like your age, your gender, whether or not you have diabetes, your family history, whether or not you have high blood pressure, if you're taking medication for high blood pressure, what your cholesterol panel is, and it can even include something called a calcium score. If you plug all of those factors and all those numbers into this risk score, it will then put out a score. And based on that score, it'll even give you advice on what would be the appropriate therapy for you. And these scores and these tools can all be found on the internet these days, and there are all sorts of apps that you could pull up to help guide your decision-making process and the decision that your doctor needs to make. Another way to help decide whether or not somebody should or should not be on cholesterol medication is with a test called a calcium score. A calcium score is a CAT scan uh, that takes about 30 seconds. There's no injection, no dye, no needles. Simply lay on the table, hold your breath twice for 5 seconds during the study, and 30 seconds later, an image is taken of your heart arteries, and the calcium deposition in your arteries is calculated. Calcium is a component that's found in atherosclerosis or plaque. The calcium score is a surrogate for how much plaque you have. So based on your score or the presence of plaque, that is an added factor in helping decide how aggressive your physician and you want to be about minimizing your cholesterol numbers or getting to a particular target. It will also help you decide how low your blood pressure should be, where your diabetes should be, how much exercise, and all sorts of things. And they can help develop a preventive plan for you. And sometimes we find that people may have a lot more plaque in their arteries than they think they do. Of note, this test is not for people who already know they have coronary disease or have had bypass or stents. This is for people who have no idea what's going on in their hearts. They're between the ages of 40 and 75. They have risk factors, no symptoms, and you just want to get a baseline of what's going on so that you can develop the best plan for yourself. Next slide. So what are your options if your cholesterol is high? Every single person should focus on diet and exercise. Everybody. Minimum amount of exercise is at least 2.5 hours of moderate intensity exercise weekly. That's a brisk walk. So 30 minutes of brisk walking 5 days a week, and that's the bare minimum. But you want to do more than that if you want to get more out of your activity. And diet, people always ask, what's the diet? What should I eat? I mean, the Mediterranean diet is considered the best diet, and it's really not a diet. It's just a way of eating. It's a lifestyle. You shouldn't do fad diets because those never last for a long time. Mediterranean diet focuses on healthy foods, chicken, fish, vegetables, fruits, olive oil for your dressing and for cooking, and tree nuts, pistachio, walnuts, almonds, a handful a day. And the easy way to think about it is Just stay away from anything that's processed, anything that's in a package, anything that's in a can. Try to make your food fresh, and lay off of too many carbohydrates. Then you have choices of medication. Your doctor may say, we need to lower your cholesterol because diet and exercise is just not going to get you to goal. Um, when we evaluate you and we determine that you have particular risks or problems, we have a target in mind of where we want you to get to. If you ate lettuce every day for the rest of your life, we may be able to only lower your cholesterol about 20%. All right, so oftentimes diet is just not going to cut it. So we go to medications. We want to use medicines not just because they lower your numbers. We want to use medicines that lower your numbers and also have proven to reduce your risk of heart attack, stroke, and death. Currently, there are only 3 agents that have proven that repeatedly. Statin drugs have been around for almost 5 decades, and there are multiple trials proving their efficacy. And there are ongoing trials looking at all various types of situations, and each of these trials are showing that when people have high risk features, have had heart attacks, have had bypass, have had stents or strokes or peripheral arterial disease, that the lower we get that LDL, the better it is for preventing another event. The other drug besides statins that leads to a reduction in heart attack, stroke, and death are a class of drugs called PCSK9 inhibitors. They inhibit an enzyme, a receptor in the liver, and they help eliminate the production of this bad LDL. These are safe, have been around for a little bit more than 10 years. They're very effective. The downside is that they're expensive, and the insurance companies want 2 things or 3 things. 2 things: failure of 2 statins and evidence that you have coronary artery disease or vascular disease, which is why sometimes in my patients who can't tolerate statins, I'll get a calcium score. And if they have the presence of plaque in their arteries, I can send into the insurance company that there's plaque, they failed 2 statins, and this is an alternative medicine that has doesn't seem to have the side effect profile that statins have. No muscle aches, no pains, no liver problems. The other drugs, and it's fairly new, is a drug called bempedoic acid. Works on the same pathway that statins do, but on a different part of the pathway, so they don't seem to affect the muscles, and there's no muscle aches and pains and muscle weakness. But this drug has been around for just a couple of years. It's still a brand name, and it's still quite expensive. Um, Zetia is a drug that blocks the absorption of cholesterol in the stomach or in the intestine, and that usually is combined with these 3 others to help lower the number to the target goal. And then sometimes we use these other medicines, fenofibrates, niacin, bile acid sequestrants, when people are having problems with the first 4 meds that I mentioned, or they have specifics about their cholesterol that need to be addressed. For instance, people with very high triglyceride levels, they might be placed on fenofibrates. So next slide. So for those who do not have confirmed atherosclerosis, you walk into your doctor's office for your annual visit. They check your cholesterol and all the other labs. They get back this panel that has your total cholesterol, the LDL, the HDL, the triglyceride, the non-HDL, and they see that it may be elevated. They then determine, are you a low risk, a borderline risk, an intermediate risk, or a high risk individual? And then based on what your level of risk is, along with your cholesterol panel, there are recommendations that have been made by experts in the field who get together every couple of years. They review all the data that's been available before, and all the new data, and they come up with recommendations. But this is something that you talk with your doctor about when you make these decisions about starting medication. Um, Oftentimes helpful in these individuals who don't have any evidence of atherosclerosis is to get that calcium score, because if you have atherosclerosis, it changes the situation a bit. Let's go to the next slide. And then what if you have atherosclerosis? So if you have any evidence of atherosclerosis, such as an abnormal calcium score, you've had a stent placed, you've had a heart attack, you have carotid disease, you had carotid surgery, you have vascular disease, plaque in your legs. Um, if you are less than 75 years old or equal to 75 years old, there are recommendations. If you're greater than 75 years old, you may not be as aggressive, but there's still data that does indicate a benefit of lowering cholesterol with statin therapy. And then there are individuals who are very high risk. These are individuals who have had events, they continue to smoke, they're diabetic, um, their blood pressure is not optimally controlled. Those individuals are high risk for another event, and the targets for those individuals are much, much lower. Next slide. So what are the high risk conditions, or what are the major events? So if you've had a recent heart attack or have had a history of a heart attack or a stroke, as I mentioned, and the high risk individuals in that cohort are people above the age of 65, familial genetic hypercholesterolemia. These are very high levels of cholesterol, prior bypass, prior stenting, diabetes not well controlled, hypertension not well controlled, kidney disease, current smokers, and history of congestive heart failure, and if your cholesterol is persistently elevated. Next slide. And so what are the LDL targets for secondary and primary prevention? So secondary, again, these are individuals who have disease. They may be high risk, they may be very high risk. And you could see that if you on that slide on the left, if you have your LDL checked, and for instance, we'll look at the top number and it happens to be 100, the goal is to try to get it down to 50. Right? So if anybody says, oh, your cholesterol's fine and you have a history of vascular disease, and they say your LDL is okay, it's not true. There's data to support that getting it down to 50 is going to mitigate your risk of events. So, all of this is based on scientific data. Um, Lots of trials that look at individuals in all these different categories with various baseline cholesterol levels compared to groups who don't get statins or don't get treated. And in each of these trials, there's always been proof that getting these numbers down substantially leads to a reduction in events. What about primary prevention? In individuals who don't have any evidence of atherosclerosis, but they have high risk features, um, the goal is to get that LDL down to greater than or equal to 35% from its baseline. So not to be as aggressive. And then let's say, all right, you get treated and you're in that primary preventive group. It doesn't end there. You continue to follow closely. You may get a calcium score 1 year and it's 0. We'll do it again in about 4 to 5 years. Because if it comes back that now you've got evidence of atherosclerosis, you've got to reevaluate where you are with your blood pressure, your cholesterol, your risk factors, and intensify the preventive treatment. Next slide. Um, a lot of people stop statins and a lot of people don't take them. And why is that? Sometimes it's cost, although that's not as much of an issue now that they're all generic. Um, Sometimes the doctor that's prescribed you the medication isn't really doing a great job of following you. Sometimes doctors are more concerned about giving you the statin than they are about the complications of not giving you a statin. And look, that happens. Not every physician agrees with the science. But I could tell you that the overwhelming number, if not every cardiologist, endocrinologist, um, vascular surgeon, cardiac surgeon, all believe in statin therapy. Sometimes it's patient factors, right? Uncertainty of the benefit. Some people just, don't really want to take the medication, or they're not motivated by it, or they don't think it's going to help that much. Um, it's a safe, inexpensive, cost-effective way of reducing your risk of cardiovascular events, period. And some people are worried about the side effects. There are many folks who are, um, you know, they're convinced before they even take the medication that there's a problem with it, that once they start the medicine, they swear that they're feeling problems from it. These are called nocebo effects. Some people do have true myalgias and myopathy. And what's the percentage of people that actually truly have side effects from statins, Lipitor, Crestor, Zocor, those kinds of meds? It's about 5%. And how do we know this? Well, we've done trials. There's one really important one where we took two groups, large numbers of patients, and neither the patients nor the providers who were distributing the medication knew what they were getting. Well, one group was getting statins, the other group was getting a medication that looked just like the statin, tasted just like the statin, but wasn't. And they took it for 3 months, and we asked them about symptoms. Then we flipped it without anybody knowing that we flipped it, continued to ask for symptoms, and then we analyzed all of the data. And what we found was only 5% of those patients truly had statin-induced myalgias and myopathy. So it's not as much as is believed out there. A lot of times people are older, they have joint pains, muscle aches, this, that, and the other, and it's important to not confuse run-of-the-mill muscle aches and pains for true statin-induced myalgias and myopathy, muscle aches and weakness. So talk to your doctor before you just go ahead and stop it. Some people say it causes brain fog. Some people, and then there's also a lot of myths around statins. Some people are concerned it causes Alzheimer's. That's debunked. Some people think it causes cancers. That's debunked. Some people thinks it causes, all these different issues, but all of it is debunked. And as far as the liver problems, we do check the liver every couple of months. And once you've checked it twice and there's no liver problem, it is very unlikely you'll have a liver problem from the statin, and if you do, it's from something else. And ever since we got rid of a statin called Baycol, probably about 35, 40 years ago, there has not been one liver death from statin therapy um, since then. Let's go to the next slide. All right, so I'm hoping that I partially explained why it's important to take statins. Um, Hope I've answered some of your questions about why they're important, and or other cholesterol medicines, why cholesterol is important to treat, and uh, and hopefully relieved some of your concerns around taking these medications. And now I'm open for questions.
All right. Well, thank you, Dr. Ari. That was fantastic. I learned a lot. We do have some questions in the chat. I will read them out in the order we received them. The first one is, how does perimenopause factor into the right drug and exercise formula? I've never had any issues with my cholesterol before, but the last couple of years it's gotten higher no matter how healthy I eat.
Yeah, so perimenopause. So there's two parts to that, two answers to that question. So when you hear about women have the same amount of uh, or risk of developing heart disease as men do, and that women have, historically been excluded from a lot of the trials. That's changed, over the last, I'd say 15 to 20 years. Um, the reason those women who do begin to equal the incidence of vascular events as men do are women who are typically 10 years postmenopause. Estrogen has a protective effect. So if you have either a hysterectomy or you've gone through menopause, after 10 years, your risk of vascular disease, atherosclerosis, heart attack, stroke is equivalent to that of a man at the age of 55. So it's true that women and men have equal events, but that's when women are usually in their 60s as opposed to the men in the 50s. The issue about, how does menopause change or perimenopause change, the cholesterol? Um, it, it may have nothing to do with that. It may have to do with the fact that the genetics that drive your current cholesterol numbers has changed. And, that's why we monitor cholesterol routinely throughout your lifetime. Part of it is, your environmental factor may change, your dietary habits may change, you may get more sedentary and your cholesterol may change for that reason. Or it's that a gene in your body is activated and now your liver is producing more bad cholesterol, less good cholesterol than it used to. And it's great that you're still exercising and taking care of yourself, but unfortunately, you may at this point require help from medical therapy to get your numbers under better control. And you need to discuss with your doctor what's the benefit of me getting on medication, why, and so forth. So um, I hope that answered your question. What's the next one?
How effective is red yeast rice supplement or fish or krill oil?
Yeah, so listen, all that stuff will lower your cholesterol. Fish oil has been really proven to not be of any benefit at all. Eating large amounts of salmon might help, but taking fish oil, it's really not that helpful. Almost no help at all in people who are primary prevention, no atherosclerosis. Very little if you have atherosclerosis. And red yeast rice, and what was the other one? Krill oil.
Krill.
Again, we've tested all of this stuff. There's lots of stuff that lowers your cholesterol. But do you want something that's going to lower your cholesterol and reduce your risk of events? Or do you just want to be happy that your numbers look better? If you're just happy about your numbers looking better, then take all that stuff that doesn't do anything for you. If you actually want to not have a heart attack, stroke, or die, then take what's been proven to work.
All right. What is considered an abnormal calcium score?
So your calcium score of 0 indicates that you have no detectable plaque. But take it with a grain of salt. There's something called soft plaque, which is not detected by calcium scores. So, your doctor has to be aware of that. It's not common, but it's possible. There have been some instances where people have had 0 calcium scores. Individuals continue to have symptoms. They end up they end up going to the cath lab because the symptoms are so classic, and we find what's called soft plaque. With that being said, the overwhelming majority do have calcium in their plaque. And so a score of 0 is fantastic. If you have a score of 0, the way to interpret it is the likelihood that you're going to have an event in the next 10 years is very low. So it's a great score. 0 to 100 is a low risk score. There's plaque that's building up. You may want to consider initiating therapy. You want to begin to get a little bit more intensive about risk reduction, but it's very unlikely that you have any major disease, and the likelihood that an event will happen is low. When you start to get to 100 to 400, you're in an intermediate range. Still unlikely that you have any major blockage, but as the score gets higher, there's progression of atherosclerosis, and the risk starts to go up. Above 400 is considered high risk. So greater likelihood for an event, more reason to be intensive about risk reduction. And when you start to get in the 200 range, 300 range, you may even want to consider doing a stress test just to make sure you don't have any major blockage. Um, there are people who get in the thousands. It doesn't mean your arteries are clogged up. It just means that your risk is greater of ending up with an event. It doesn't mean you're definitely going to have an event. So if you're in the thousands, you probably should be seeing a cardiologist, and the intensity of the risk reduction, needs to be taken seriously. Even at 100, right? Your goal is not to get into the thousands. So, and the thing about risk reduction is the earlier you start in life, the more likely you're going to prevent problems in the future. Now, we all have things happen to us, right? Nobody lives forever. But by being proactive early in life, it's a greater chance that you're going to live much longer and be a lot healthier as you get to that older stage in your life. The less you take care of yourself earlier in life and then mid-age in your life, the more likely you're going to have things pop up that will sidetrack you throughout your lifetime. And they always say, at least I have my health. You want to have your health. What's the next question?
All right. How much more time do you have, Dr. Ari?
I'm good. I'm good.
Okay, I just want to make sure. Okay, why does it seem like only statins are prescribed? I hate the way they make me feel, including brain fog. I've never heard of the others, and I don't recall ever having a calcium score test.
Well, I don't know the answer to that for your personal history because, that's if you saw me, we would be investigating the other meds plus do the calcium score. Why are statins? It's because they've been around for 50 years. We know more about these meds than we do any other medication. The overwhelming majority of people tolerate them. They have led to a major reduction in cardiovascular events. The types of heart attacks that we see since the advent of statins are much less severe than the ones we used to see before statins. We know the problems they cause. They're cheap. Um, so there's a reason we go to those first. And the other ones that I mentioned, they're second line right now because they're expensive, they're new, they do have fewer side effects, or at least people, don't feel as many side effects as they do with these others. But in general, if you failed two statins, for whatever reason, then your provider should be looking at alternative options.
Does CoQ10 really help with statin side effects?
No,
Does CoQ10 really work?
no, no. We used to push CoQ10 years ago because HMG CoA reductase. It's an enzyme that's used in the muscles. That's what the statins block. And by giving CoQ10, it can prevent some of that reduction of the HMG CoA reductase in the muscle that we think causes the muscle aches and pains. So we started putting everybody on CoQ10 many years ago, and then we did the trials to see if it truly works, and it
Hey,
doesn't
hey,
work at all. But for those
can I
people
get
who it does work for, keep taking it because
can
it's
I
got
get
good
a
placebo effect.
Chick-fil-A combo, the sandwich?
Would you
Um,
get her Chile combo sandwich, please?
um, could Zetia be effective when taken alone, or should this always be paired with another cholesterol med?
So, sometimes we use Zetia alone because an individual truly can't tolerate a statin. We can't get their insurance to cover PCSK9 inhibitors, those injectables, or any other medication. And so Zetia can be used. The data on Zetia alone is not great. I mean, it will lower your cholesterol, not as effectively as the statins, and there isn't any strong outcome data that shows that Zetia is effective at reducing risk of heart attack, stroke, death. But if you have no other option, um, we believe it's better than not taking anything at all. It just, there, it's not as simple as you lower the cholesterol and you'll get the results you want. There's something about what the statins do, or what the PCSK9 inhibitors do, what the pembidoic acid does to the biology of cholesterol that leads to these clinical benefits, whereas Zetia just blocking the absorption doesn't seem to have the same sort of bang for its buck as the other drugs do. But we do use Zetia in combination with those other medicines when we're not able to get to the target goal cholesterol numbers that are necessary for the individual with whatever particular problems that individual has.
All right. Yes, this presentation will be emailed. I am recording it. We'll do maybe two more questions if that's okay. I'll just choose two.
Sure.
I think this has been a very popular topic today. All right. Any concerns regarding long-term 10 plus years of statins?
So a lot of the concerns about statins have been debunked. There were concerns about Alzheimer's, concerns about cancer, and none of those are true. Statins have been shown to raise blood sugar. And in some instances, it may be connected to causing or facilitating the development of diabetes. All right. There's no direct cause and effect, but there have been several studies to determine, does taking statins, the benefit of statins, are they outweighed by the potential risk that the blood sugar may be affected and be a contributing factor to the development of diabetes? And the answer is that statins are still much more beneficial than hurtful to you, even in the long run. Now, statins have been around again for decades. People have taken them for years. I myself have taken a statin for 20 years. I can still think. I don't have cancer, knock on wood, no Alzheimer's, this, that, and the other has never affected my muscles. I'm here, haven't had a heart attack. My father died at 47 from a massive heart attack. I've outlived him now about 10 years. So, it doesn't mean anything because you would need, several thousand identical like me and my father to truly know if it's equivalent. But no, there is no downside that we know of taking the statin for a long term.
All right, we're going to do one more question. And for those that, I apologize, we didn't get to your questions, but you can go see Dr. Ari, and I'm sure he would love you as a patient. Hopefully to give you a clean bill of health, that is. Okay, so one more. I read that reducing cholesterol could also reduce risk for Alzheimer's. What do you think?
That's true. There is some, so when this concern and question was raised about the potential risk of statins causing Alzheimer's, well, there was a lot of research that went into that. And the outcome is that statins may actually help prevent Alzheimer's. Now, or it's not, there's no strong, you take a statin and you're definitely not going to have Alzheimer's. But in the cohorts, in these trials that looked at thousands and thousands of patients on statins over a long period of time, they found that the individuals on statins versus those who were either on the placebo component of the drug or those who didn't take statins at all or any placebo, they had less Alzheimer's per capita per patient than individuals who didn't take statins. But there is no, it's not that you take a statin and you're definitely not going to have Alzheimer's. It's just that, there seems to be less, and we don't understand what the driving factor is.
Well, thank you so much. We really appreciate this. I know we went 15 minutes over, but thank you for your time. And if anybody needs uh, the office number to make an appointment with Dr. Ari, please let me know. I'll be happy to give it to you. And just thank you so much. I will be sending this recording out because I know we had a lot more people that registered and will be probably wanting to hear this valuable information as well. I hope everyone has a great weekend. Thank
Have a
you.
great weekend. Take care, everyone. Thanks very much. Bye-bye.